So I will be talking about natural history of acute and chronic hepatitis B, and my job has already been made easy because of the previous two lectures, which were wonderful, and they covered the parts of natural history as well as the serological tests. So as already told by Amit sir, so hepatitis B virus infection can be acute or chronic. So acute duration will be less than 6 months, chronic more than 6 months. It can be asymptomatic or progress to acute viral hepatitis or to acute liver failure in some cases. Whereas in chronic infection, we can have chronic hepatitis B, compensated cirrhosis, decompensated cirrhosis, and some patient may also develop HCC. So in acute hepatitis B, usually the incubation period ranges from 6 weeks to 6 months. And as in other viral illnesses, it has three phases of illness. First will be prodrome, where prodromal symptoms like malaise, fever, anorexia, nausea, vomiting, etc. will be seen, which will be followed by the icteric phase, where patient will develop icterus and will have resolution of prodromal symptoms and uh, appearance of icterus. And then if the patient will recover, then this will be known as convalescence phase, and gradual recovery is the rule. And if the patient deteriorates, then he or she may land up in acute liver failure. So as already told, that 70% of the cases are usually anicteric hepatitis, and those who develop icterus will be around 30%, and only a proportion that is less than 1% will develop acute liver failure, which is a good thing because we know that acute liver failure is a very deadly illness and prognosis is very poor if not managed properly. And even with proper management, some patient may not survive without liver transplant. And age at infection and immune status of the host factor determine progression from acute to chronic hepatitis B. And if the infection has been transmitted from mother to child, there are high chances of going into chronicity. Whereas if the infection has been contacted at adulthood, then there are high chances that more than 95% of such patient will not land up in chronic hepatitis. So this graph clearly shows that age has an important age is an important factor when it comes to uh, determining whether the patient will land up in acute chronic hepatitis B or not. So here we can see that as the age of the contacting hepatitis B virus increases, the rate of chronicity decreases. Whereas those who have contacted the infection at childhood, they have high chances of going into chronic hepatitis B. So one important point is that we are more worried about chronic hepatitis B rather than acute hepatitis B from public health point of view. Although we are worried about acute hepatitis B also as a clinician or physician, because we want to see that patient is not progressing to acute liver failure, but from public health point of view, chronic hepatitis B is more important. Why it is more important? Because in chronic hepatitis B, the patient can transmit the disease to other people. So we will not be able to eliminate the disease from the society. And the patient can have long-term consequences of the disease like cirrhosis, then decompensated, and also developing hepatocellular carcinoma. Hence, from public health point of view, chronic hepatitis B, its diagnosis, treatment is of utmost importance. Now coming to acute liver failure, as I already told that only 1% of patient will progress to acute liver failure, but the severe liver damage leads to a clinical state where patient can also succumb to illness. And the more important differentiating points are that if a patient has acute viral hepatitis B and he or she develops altered behavior and consciousness, which points towards hepatic encephalopathy or bleeding tendency, which points towards presence of coagulopathy, or small liver on ultrasound, which points that the necrosis is setting in and liver is shrinking, or brain edema on NCCT, which is also a marker that patient is going into acute liver failure. All these things point that the patient is progressing to acute liver failure and has high chances of poor outcomes. So these are the warning signs which we should look in a patient with acute viral hepatitis, irrespective of the etiology. So any patient with acute viral hepatitis, if they develop these warning signs, then we should be very careful that the patient is going toward acute liver failure and the patient may need referral to a transplant center also. So this is the table which shows that how we can differentiate whether the patient has acute viral hepatitis B or the patient has acute liver failure. So prodromal symptoms will be common in both the scenarios. Sudden jaundice can be seen in both. OTPT may also be in the range of 1,000 in the both cases. And when it comes to anti HBC IgM positive, it can also be present in both. But where we can differentiate, as already told, is first is the presence of encephalopathy. Any grade of hepatic encephalopathy, we should think in the line that the patient is progressing into acute liver failure. Presence of coagulopathy, that is INR more than 1.5, it also points that the patient is progressing toward acute liver failure. And third is the liver size. If the liver is shrinking, that means that the parenchyma of the liver is getting damaged and necrosis is setting in, and the patient is going into acute liver failure. So these three things we have to keep in mind while monitoring a patient of acute viral hepatitis. So after acute viral hepatitis, let's come to the more important part, chronic hepatitis B. So the natural history of chronic hepatitis B, it is a fight between the host immunity and the hepatitis virus. So if the immunity of the patient prevails over the virus, then we will have clearance of the hepatitis B from the body. And on the other hand, if the virus has the upper hand, the virus will definitely proliferate in the body and will dominate over the host immunity. So the interplay of these two things dominate, and in which phase we may detect the hepatitis B virus in a patient. So chronic hepatitis B, the natural history can be divided into immune tolerant phase, immune active phase, inactive carrier phase, and HBsAg clearance or cure phase, and in some time reactivation phase. So this picture clearly depicts the different phases of the natural history of the hepatitis B virus. So this is the first phase, which is the immune tolerant phase. Here the HBV DNA will be high and ALT levels will be low. Why? Because the patient's immunity is not fighting against the virus, and the virus is allowed to replicate in the body, but the virus is also not causing damage to the cells, because the immunity, if it gets activated, then only the hepatocytes will be destroyed and AST/ALT will rise. So in this case, although HBV DNA levels are high, but ALT levels will be low, meaning that although the virus is proliferating in the body, but it is not causing any damage to the hepatocytes. So this is called immune tolerant phase. And the important thing to be noted is HBeAg will be positive in this case. Why? Because as already told, HBe is a marker of proliferation. So the virus is proliferating in the body. That means HBeAg will be positive. So this is the immune tolerance phase. Next comes the immune active phase. So in immune active phase, there will be a continuous tussle between the hepatitis B virus as well as the body's immune cells. So sometimes the HBV DNA will go up, and when the immunity will have upper hand, the level will come down and the AST/ALT will rise, because as the immunity will fight the virus, the virus infected hepatocyte will get destroyed and ALT will be raised. So this is a continuous tussle which will be ongoing in this immune active phase. And as we see, the HBV DNA level may be high or low in this case, and they will fluctuate. And the important thing is the ALT level will be higher in this case, and HBeAg may be positive or negative, because if the immunity is able to control the virus, then HBeAg will become negative, and if the cells are proliferating, then it may be HBe positive. This is a stage of active hepatitis, and if active hepatitis is there, then if we subject the patient to liver biopsy, then variable degree of fibrosis may be seen. So this is the phase of the hepatitis B in which treatment is required. In first phase, that is immune tolerance, there is no need for treatment, although you may have misconception that the HBV DNA level may be in millions, but if ALT level is normal and on imaging there is no evidence of cirrhosis, then there is no treatment for immune tolerant phase. Whereas in immune active phase, with fluctuating HBV DNA levels and AST, ALT being more than upper limit of normal, such patients require treatment. So that's why we need to differentiate between the different phases of chronic hepatitis. So then, when the host immunity is able to take control of the situation and the HBV DNA levels are suppressed, so then the patient will progress to inactive HBsAg, meaning that the HBV DNA has been suppressed and HBeAg positivity has been converted into HBeAg negativity, and anti-HBe antibodies will also appear in the blood. So there is no activity to subject such patients to liver biopsy. No activity will be seen, meaning that no inflammation, no fibrosis will be seen. And if at all moderate fibrosis is seen, it may be because of the previously damage which has been done. So this stage is also doesn't require any treatment. And then comes the reactivation phase. So there is always a chance of HBV reactivation phase, meaning that even if the HBV DNA levels are suppressed, as Sir told, that they integrate with the DNA of the patient. So such patients at any stage, if they develop immune suppression because of corticosteroid, chemotherapy, or any stress to the body like acute surgery, so the HBV DNA can once again start proliferating and can once again have a resurgence in the HBV DNA level. So such patient also require treatment. Treatment is required in case of HB immune active phase as well as reactivation phase. Whereas in immune tolerance phase, although the HBV DNA level within 1,000 millions, doesn't matter if ALT levels are normal and it is not causing any damage to the hepatocytes, no treatment is required. So that's why natural history of chronic hepatitis B is important. So let's now revise what all markers will be present in the different phases. So as I told, in immune tolerant phase, ALT levels will be low, HBV DNA will be high, HBeAg will be positive, anti-HBA will be negative, and no need of treatment. Coming to immune active phase, AST ALT levels will be high, HBV may be moderate, it may be low, it may be high, depending on the whether immunity has an upper hand or virus is having moderate hand. And HBeAg also may be positive, negative, doesn't matter. Anti-HBA may be positive, negative. Need for treatment? Yes. Then comes inactive carrier phase. ALT will be low because virus has been suppressed, so there is no inflammation. HBV DNA will be low. HBeAg, anti-HBeAg may be positive or negative, and no need of treatment. Then comes reactivation. Reactivation means that suppressed DNA has once again has a resurgence and it is once again proliferating. And if it is proliferating at a higher level, it may have higher DNA levels, otherwise it may be low also. And need for treatment is there for reactivation. And scenarios for reactivation are that mostly if the patient is subjected to corticosteroids or any immunosuppressive therapy, or patient develops malignancy, or any acute stressful event which causes immunosuppression, or in old age diabetics. So in such patient, reactivation can be there, and they definitely reactivation requires treatment. So as is the case with the any chronic hepatitis, so prolonged chronic hepatitis B infection will progress to liver cirrhosis, and liver cirrhosis is a fertile soil for HCC, and around 4 to 5% per year can develop HCC, those who have cirrhosis. So to summarize, HBV DNA infection in infant or small children has high risk of progression to chronic infection. HBV infection in adults results in acute hepatitis with spontaneous clearance in 90 to 95%, and less than 1% may progress into acute liver failure. Chronic hepatitis B infection has several stages with progression to cirrhosis and liver cancer in a proportion. And those who develop decompensation and HCC have higher chances of fatal outcomes. And important thing to remember is that liver cancer can occur even without cirrhosis. The reason has already been told by Amit sir, that the virus integrates with the host DNA, and even if the HBV DNA is not detectable in blood, it may cause low level inflammation and release oncogenes, which may in turn cause HCC. So HCC surveillance is required in chronic hepatitis B patient, even if they do not have any detectable HBV DNA levels. And amongst patients with chronic hepatitis B infection, only those with elevated ALT and high HBV DNA need the treatment. That is, those who are in immune active phase. This thing needs to be kept in mind.